Good. Good morning, everybody here and online. It's my pleasure to introduce Dr. Mahowald. I can't tell you how long it took me to learn that last name, because as a German, I had no idea, like, how can I get the May? So in German, I would say Mahowald, like, yeah. I'm like, why is she doing that? But yeah, so nice. And to present her, one of our interventional fellows for the last couple of years, we had two. You are the second year with two, and the first year with actually our structural fellows staying on. So they were like a super fellow. That's kind of interesting. A couple of stations here for her. She's from a Bachelor's of Arts in Santa Fe. Then she did, and we just talked about it, internal medicine and pediatrics. I learned that 4 years is both. Yeah, I didn't know that. In Michigan, and then Minnesota, Rochester, where some of us trained as well for cardiology training, and then she came here for interventional cardiology. She has published about 17, 18 papers, couple from here now, which is always great in review. And she has a job. She's going to be an assistant professor at the University of Florida. Congratulations. Maybe at later stages, structural heart disease or so, we'll see. Anyway, she's going to give us some coronary revascularization guideline updates. And if she passes her exam tomorrow, which she didn't know she has, then she will be an interventional cardiologist soon. Good luck.
I actually studied philosophy in undergrad, and then I wanted to do something more like long division, where and no matter who approached the problem, there would always be one single correct answer that everyone would agree on. So I chose medicine. You can imagine my surprise. So the guidelines are what I used to think sort of the closest thing we had to the things that everyone would agree upon. And the more I learn, it seems like the less black and white there is in medicine and the more gray area. So this is an opportunity for us to kind of go through some of that gray area. I'll present some of the data behind how people came to these decisions, and then how reviewing the same data, people can still draw different conclusions. Our goals for today, first was the class 1 indications for revascularization. 2, we'll spend a little time discussing the Ischemia trial, how the methods of that trial and how the results have really impacted the current guidelines. And we'll highlight some of the changes in classes for recommendation that are pertinent to our practice. This document had really big shoes to fill. It replaces in entirety or in part 6 prior document statements. So we won't be able to cover the entire thing in an hour. The things I'd like to focus on are the acute coronary syndrome management. Then we'll talk a little bit about stable ischemic heart disease. And in that context, we'll discuss the Ischemia trial. And then finally, we'll discuss some of the procedural technical recommendations, which is where a lot of the controversy has developed. Before we get started, let's make sure we're on the same page as far as lesion severity. Traditionally, that has been defined by angiogram, either 70% stenosis in a non-left main lesion or greater than 50% stenosis of a left main lesion. Speaking of gray area, it seems like those intermediate stenoses are a key area for gray area, and coronary physiology now has a class 1 recommendation for intermediate stenoses, at least in cases where ischemia has not previously been localized and diagnosed either based on stress testing or EKG. There's a class 3 recommendation against fixing anything that is not physiologically significant. IVUS has a class 2A recommendation, and specifically mentioned is the area of left main disease to help define lesion severity. And later in the document, OCT gets a 2A recommendation as well for procedural guidance. The syntax score is something that we talk about a lot, but I'm not sure how many people actually calculate. It's used primarily in determining, in quantifying multivessel disease and helping to guide determinations of best options for revascularization. It's a 2B recommendation here. So we'll start with STEMI. In a sense, that's the simplest recommendation because most of us, our knee-jerk reaction is to take these patients to the cath lab. So there's a class 1 recommendation for patients who have had symptoms for under 12 hours. Also a class 1 for patients who have received lytics but have failed reperfusion. And then anyone, regardless of the timing of symptom onset, in cardiogenic shock or hemodynamic instability. Now, if you've had symptoms between more than 12 but under 24 hours, then you move to a class 2A indication. Also, routine revascularization after lytic therapy. And then any patients, regardless of timing or onset, with signs or symptoms of ongoing ischemia, acute severe heart failure, or malignant arrhythmias. And then finally, the asymptomatic, stable, late presenting STEMI with no signs or symptoms of ongoing ischemia, there's a recommendation against going to PCI. There is a role for surgery in patients with STEMI, especially in the setting of mechanical complications. So there's a class 1 indication for any of the mechanical complications, often which are accompanied by cardiogenic shock or hemodynamic instability. There's a class 2A for patients where PCI either fails or is technically not possible, as long as there's a large area of myocardium at risk. And then there's a class 3 recommendation against CABG unless, in patients who have failed primary PCI, unless there's a large ischemic territory and reasonable targets. People who have no reflow and really poor distal targets should not be going for emergency CABG. One thing that has changed is how we manage bystander lesions in STEMI. So in hemodynamically stable patients who get successful primary PCI of their culprit lesion, stage revascularization for complete revascularization is recommended. And now there's a class 2B recommendation to perform that concomitantly in, the hemodynamically stable, carefully selected patient where a concomitant lesion is feasible to fix at the same time. In patients with complex multivessel disease, there's a 2A recommendation to send them for elective CABG following their primary PCI. And then, as we all know from the culprit shock trial, in patients with STEMI and cardiogenic shock, PCI of the non-infarct artery should not be attempted at the time of primary PCI for the culprit. And this is a change, as I mentioned, in 2013 when the STEMI guidelines were released. PCI of a bystander lesion at the time of primary PCI was a class 3 recommendation against performing. It's now a 2B. Let's move to non-ST elevation acute coronary syndrome. So this is all about risk stratification, as you all know. So patients with cardiogenic shock, medically refractory angina, hemodynamic or electrical instability, they all need an immediate invasive strategy. Then everything else is a 2A. So patients who are at high risk for clinical events, in here defined as a GRACE score greater than 140, should go to the cath lab within 24 hours, is reasonable to go to the cath lab within 24 hours as long as they're appropriate candidates. And then initially stabilized patients at intermediate or low risk for clinical events, often determined by GRACE score. They are, we usually, so in that case, it's reasonable to send them to the cath lab within 72 hours or prior to hospital discharge. The European guidelines are a little more aggressive with regards to invasive strategies in STEMI or non-ST elevation acute coronary syndromes. So again, they talk about risk stratification, but when they talk about a high risk criteria, anyone with an NSTEMI counts as high risk. Anyone with ongoing ischemic changes on their EKG, transient ST elevation, or again, a high GRACE score. All of those people, they recommend an early invasive strategy. Now, patients at low risk by risk stratification calculators can either get angiography or they can get ruled out by stress testing or by coronary CT as an appropriate way to alternative to invasive strategies in their management. So now we'll talk about revascularization and stable ischemic heart disease, and here things get a little bit messier, and we'll talk about the Ischemia trial. The first bifurcation for stable ischemic heart disease is what your goal is. So if your goal is to alleviate anginal symptoms, then revascularization gets a class 1 indication, regardless of whether it's by PCI or CABG. And that's it. Everything else is about whether or not you can improve mortality. And they're quite clear that the only class 1 indications to improve survival in these patients are left main disease, in which case they recommend CABG, or multivessel disease with severe ischemic cardiomyopathy and an EF less than 35%. Those are the 2 class 1 recommendations for CABG for survival. Let's start by talking about that highest risk group, the low EF multivessel disease. A lot of the data for that comes from the Stitch extension study, the surgical treatment for ischemic heart failure extension study, which was published, the 10-year follow-up was published in 2016. And so these were patients who were randomized to optimal medical therapy or optimal medical therapy plus CABG. They were all severe ischemic cardiomyopathy with an EF less than 30 to 35%. And the first thing that sticks out to me is how astonishingly high their event rates are by 10 years out. And also that the curves diverge quite clearly. This is not one of those New England Journal articles with a little inset with a very magged up graph for you to be able to see the actual treatment benefit. It's quite clear that these curves diverge. The primary outcome was death from any cause. When this was first published at 5 years of follow-up, it was not significant, but after 10 years of follow-up, it became statistically significant CABG benefit over OMT. And that's true for death from cardiovascular causes and death from any cause for cardiovascular hospitalization. And this is really one of the things I feel like CABG for severe multivessel disease and ischemic cardiomyopathy is one of the core tenets of cardiology, and I think this forms the basis for that. Now, if you have normal preserved EF or mild to moderately reduced EF, things change a little bit. Now, a lot of that data comes from Ischemia, the International Study of Comparative Health Effectiveness with Medical and Invasive Approaches. These patients all had moderate to severe ischemia on stress tests with imaging, or because of slow enrollment in 2014, they added eligibility for patients who had severe ischemia on exercise stress tests. Primary outcome was the composite of CV death, MI, or cardiac hospitalization, including unstable angina, heart failure, or resuscitated cardiac arrest. Secondary outcomes, the composite of CV death or MI, and angina-related quality of life. Important exclusion criteria include recent ACS within 2 months. This is really designed to be looking at patients with truly stable disease, severe CKD, stage 3 to 4 heart failure, or other class 1 indications for revascularization, so medically refractory angina or severe unprotected left main disease. The goal was to enroll 8,000 patients over 4 years. After 5.5 years, they managed to get a little over 5,000. I think there were 320 sites in 37 countries. And the cohort was predominantly male. The median age was 64 and the mean EF was 60%. 42% of patients had diabetes in this trial. One of the nuances of this trial is that most patients had a coronary CT to confirm that they did in fact have obstructive coronary disease, as well as to rule out unprotected left main disease. You can see that a quarter of them did not, although half of those patients, 700 of them, it was because they already had known anatomy, or either they had a recent angiogram or a recent CT. So there are about 700 patients of these 5,100 who had did not have known coronary anatomy at the time of randomization. In this trial, the randomization is to initial treatment strategy. And so the 2,500 patients who were initially randomized to invasive strategy, of those, 96% underwent angiogram as anticipated, and 80% were revascularized with PCI or CABG. Of those 80%, about 3/4 of them underwent revascularization with PCI, and then about 1/4 of them got CABG, 26%. Median follow-up of 3.2 years. In the 2,500 patients who were assigned to an initial conservative strategy, a fair number of them, well, 1/4 of them ultimately underwent angiogram and over 3.2 years of follow-up, and 21% underwent revascularization. Not all of those are crossovers. Instead of there are 19% of them who underwent angiography and 15% who underwent revascularization before hitting a different primary endpoint. And so the results, I'm sure you all know this is often considered a negative trial because there's no statistically significant difference in the primary composite outcome or in any of their secondary outcomes. One thing that I would like to point out when you look at panel D in the bottom right is that, not surprisingly, patients who undergo an initial invasive strategy have a lot more MIs early on, and those are all procedural MIs, versus the conservative strategy where there's a sort of slow and steady uptake of spontaneous events. After about 2 years, the conservative strategy sort of catches up, if you will, with the invasive strategy. And in that case, you could say it's, maybe you could say it's equivalent, but in reality, other data have shown that the prognostic impact of a procedural MI is not the same as the prognostic impact of a spontaneous MI. And so patients with spontaneous MIs, not surprisingly, do much worse than patients who have procedural MIs. So perhaps just looking at the numbers do not tell a complete story. Because of that difference, there is now a two-way recommendation to reduce MACE with revascularization. So patients with stable ischemic heart disease, multivessel CAV, who are appropriate for revascularization, it's reasonable to do that to lower the risk of MACE, which is new and different from the teaching that I was always told that stents do not, unless you're having a STEMI, stents do not save lives and they don't prevent heart attacks. It seems like that's probably not the full story here. Of note, they recommend either CABG or PCI with the 2A, and we'll discuss that a little bit later. So now let's talk a little bit about the left main disease patients. Regardless of anatomic complexity, severe left main disease, class 1 indication for bypass surgery. In selected patients, if PCI can provide equivalent revascularization, it's reasonable to improve survival. It's a 2A reasonable alternative. Many of the surgical societies, for understandable reasons, would argue that it's impossible to provide equivalent revascularization for PCI and CABG because the mechanisms by which we treat those lesions are different. And we'll discuss that a little bit later too. There's way too much data to cover here about left main disease. This is a recent meta-analysis of Noble Excel pre-combat and syntax. There's about 4,300 patients altogether here. Their primary outcome was all-cause mortality at 5 years after intervention. The conclusion they drew is that there's no statistically significant difference in outcome between these patients. But the catch here is that the median syntax score of this group is 25. And as many of you know, that's sort of at the intersection between low and intermediate complexity. And so for patients in that low to intermediate complex anatomy, there may in fact be equivalency. We'll see, long-term follow-up is not shown here, but there may be equivalent strategy. I think the problem with trying to run a left main trial is that patients with high anatomic complexity are never going to be randomized, and people are always going to send them to surgery. And so that might just be how the left main debate settles out. Let's spend a little time discussing procedural considerations in PCI. Here, one of the big changes is the class 1 recommendation for a radial approach, both regardless of clinical scenario, both in patients with acute coronary syndromes and stable ischemic heart disease. In acute coronary syndromes, you can see there is data to show decrease in death, non-fatal MI and stroke, and non-major bleeding. And then in stable ischemic heart disease, there's robust data that shows a decrease in bleeding and vascular complications with a radial approach. Stent selection, no reason to use bare metal stents anymore. When it comes to MI, restenosis, or acute stent thrombosis, drug-eluting stents are always superior, even in patients who require short DAPT for whatever reason. And then finally, intravascular imaging for procedure guidance. There are decreased MACE at 3 years for both OCT and IVUS have evidence for that. And that's mostly for optimizing stent placement and sizing, which we understand leads to better results. Let's talk a little bit more about the radial and femoral debate. So this is a meta-analysis that was published last year in CCI, 31 trials, and this included both patients for ACS and patients with stable ischemic heart disease. On the left of this plot shows favors radial, and on the right it favors femoral. And here it shows there's a survival advantage with an odds ratio of 0.74 for radial access. Now, Dr. Travers and I were actually just talking about this earlier last week, that most of the data that supports a survival advantage comes from trials that were performed before 2010, and that the gap is probably narrowed significantly with the use of closure devices for femoral access, as well as a downsizing of the standard sheath used for coronary angiograms away from an 8 or 9 down to a 6 or 7. There's also less major bleeding, and I don't think that surprises people with radial access, the odds ratio 0.53. There is no significant difference between femoral and radial access in terms of myocardial infarction or in terms of procedural stroke. Moving on to other procedural technical issues, hemodynamic support. You may think this doesn't apply to you if you're a non-invasive provider, but your patients will think otherwise because they are being marketed to directly and encouraged to take a little online survey to see if the Impella is right for them. There's also a link to help you find a hospital that can put in an Impella for you. And so this is, I think, an interesting shift in patients who are really seeking out protected PCI. In this case, they do give it a 2B recommendation in selected patients, which I was actually a little surprised by that, even because randomized controlled trials have not shown any benefit in terms of survival, myocardial infarction, stroke, or repeat revascularization. However, kind of like the severe left main with high syntax scores, people probably aren't going to randomize their patients that they're unwilling to perform PCI on unless there's an Impella in place. I do want to spend a couple minutes on CTOs, and Dr. Burke, or if Dr. Berlakis is on, I'd be very interested in hearing your perspective, or anyone else in that realm. The CTO got a bit of a downgrade in this class of guidelines. In 2011, the guidelines for PCI said that PCI for a CTO in patients with appropriate clinical indications, meaning symptoms, suitable anatomy, and experienced operators was a class 2A. In current guidelines, patients with suitable anatomy with appropriate indications such as symptoms, still get a 2B with the uncertainty as the best that they, with uncertainty as the conclusion that they draw. People argued that they should have put in something with operators with appropriate expertise, and that maybe this is a little too harsh. But I think that this is part of the struggle with CTO PCI. I'm going to go over just a little bit of the data that has been published since 2011 that helps shift those guidelines down the classification grading. So decision CTO. This is a big randomized trial of 800 patients. It was a randomized trial with the composite endpoint of death, MI, stroke, or any repeat revascularization. Recruitment enrollment was rather slower than anticipated for this trial, so that may affect the power to detect a difference. And interestingly, it's a negative trial, there's no significant difference. But of those patients categorized in medical therapy only, the no CTO PCI group, 20% of them within 3 days of randomization crossed over to CTO PCI. And so that 20% probably muddied the waters significantly. This is Euro CTO a little earlier. This looked primarily at quality of life and symptom burden. Here is about 400 patients, and it did show that there's a benefit in anginal symptom burden in patients who undergo CTO PCI. Not surprisingly, the people with the greatest symptom burden are the ones who had the most benefit. And then finally, people have been looking at other ways to look for reasons to support CTO PCI as well. This is another randomized controlled trial. And this is in patients who presented for STEMI and were found to have bystander CTO non-culprit lesions. 300 patients randomized to either PCI of their CTO or just medical therapy only. After a quick short follow-up, just 4 months, they evaluated their echo parameters of LV structure and function, and there was no significant difference amongst patients who were revascularized or not. The one subgroup where there was a signal of difference is patients who had an LAD CTO. The LAD CTOs who underwent PCI did have a significant improvement in EF, and it was actually 47 versus 40%, which I would argue is a clinically meaningful difference as well. We'll talk a little bit about bypass surgery. This is another area of controversy. So the radial artery has been recommended as a class 1 recommendation to go to the second most important vessel after the Lima to LAD, also a class 1 recommendation. And the bilateral internal mammaries has a 2A classification recommendation for use when performed by experienced operators. So what do the surgical societies think of all of this? Not much. They withdrew, both the STS and the ATSS withdrew their support of the guidelines despite having participated in a lot of the literature review and the writing of the guidelines. And I think it's worth discussing why they did so. This editorial was published in the Annals of Thoracic Surgery around the time of publication of these guidelines, and they outlined their 3 main objections. So first of all, they objected to the downgrade of 2 classes from 1 to 2B for CABG to improve survival for 3-vessel coronary disease and preserved EF. And the ischemia trial was used to justify, in part, to justify this recommendation, especially because some of the older trial data that supported a class 1 recommendation is old enough that it's questionable whether or not it's obsolete now that medical therapy has changed so much. The surgeons argue that surgery has made progress too. When they did the Stitches trial, to be a surgeon within the Stitch trial, you had to have, I think, an operative mortality of less than 5%. And the FAME3 trial that was just released, the operative mortality was much less than 1%. So things have changed on both sides. And then the class of recommendation downgrade from 1 to 2A for CABG to improve survival for 3-vessel disease with a mild to moderate reduced EF. Objection number 2 was when we talked about revascularization to prevent MACE. They object that CABG and PCI are not equivalent. And it's probably true. There's more data supporting CABG to prevent MACE from stitch from Berry 2D than there is for PCI to reduce the risk of MACE. And there's a mechanistic explanation for that as well. So that I can see that that being justified as well. And then the class of 1 recommendation for radial being equivalent to lima and higher than the recommendation for the bilateral internal thoracic arteries was another objection. And to be honest, in clinical practice, I don't see nearly as much multi-arterial grafting as the guidelines might suggest that you would see. However, this is just one angiogram that I wanted to look at in the setting of these guideline changes. And I can tell you that, so there are severe lesions in the circumflex and right, and I can tell you that the LAD is functionally significant as well by IFR 0.83. Dr. Gessler, if this was your mom, how would you want her to be treated?
I would tell her what you just told us. I think that I personally still think that there's a benefit from CABG.
If this were my mom, I would want to send her to CABG too.
Same time, I think she has, and I think an experienced interventionist, I think it's best. But
yeah, I can tell you in this case, fortunately, this is not my mom. This was a 95-year-old, very frail gentleman who came in, and Dr. Mooney did an outstanding job revascularizing all 3 vessels and got a really nice result. So 95-year-old is a different situation. But if this were a reasonable surgical candidate, despite that change in guidelines, I guess I'm still convinced that surgery does have additional benefit. There are a couple of additional trials that we could talk about. Mostly the point here is that the guidelines are outdated almost as soon as they're published. It seems like there are just so much great research coming out all the time that it's hard to know in what context to put these guidelines. Instead of diving too deeply into these trials, though, I would be very interested to hear the perspectives of the experienced providers in the room. I'm not sure if anyone has any input. Dr. Burke, I don't know if you have any comments on the CTO change and recommendation, or if anyone else has criticisms or compliments for the guidelines.
Thanks for putting me on the spot. I think in terms of CTO, it's clear. And the 2A, 2B doesn't really change, my approach at all. It's for people who have refractory symptoms despite medical therapy. To my mind, in the majority of patients, it definitely makes an impact on them. But they need to understand that going forward, and that it is a little bit higher risk procedure. And you need to include the patient in the decision-making process there. You can't just be, going off on your own and deciding to do things.
Thank you. Any other questions or comments on the?
I would hope that the people who criticize the PCI guidelines tell the surgeons that they represent that we're looking for surgeons who are willing to take on these kind of cases. I mean, I'm not saying just here, I mean everywhere, right? So I think it's just like there's a shift also, I think, in the general surgical approach, like, this can be done by PCI, so why don't we just avoid our risk? I think it's kind of interesting that society is so against this. At the same time, in real practice, you often see that notion like, okay, can you do this in PCI? Well, why don't you go ahead? And I think that's interesting, right?
Thank you, Maddie, for this presentation. I was curious, one of your earliest slides mentioned evaluation of moderate stenoses, but, angiographic 50 to 70%. What are your thoughts about that? Because I've always been curious about the mistakes we might make when we, say that's nothing, when in reality, that's not the case. So could you elaborate a little bit on that?
Yeah, of course. And I think that as an interventionalist in training, I think my perspective is probably significantly different from people who did not grow up with IFR. And so for me, my knee-jerk reaction is anything that looks moderate, if it's not obvious to me, would be to get physiologic testing. And in fact, I think it is harder for me to make a decision without that as a bit of as an aid than it is for people who have been in practice a long time, who are used to me calling those shots based on visualization alone. Another thing that I think that physiology makes sense for that the eye cannot distinguish is how much flow is required to that territory and how long the lesion is, which does have, in physics that has an impact. But when we are judging, just diameter stenosis, it doesn't. One of the things that makes physiology a little tricky is that fixing one lesion can change the physiology assessment in your intermediate stenosis. And I think the data that I'm most familiar with is in CTOs, if you have a CTO of the right and an intermediate stenosis in the LAD, if you IFR the LAD, there's a good chance it's positive because it's eating the entire right territory. But then if you fix that CTO, your LAD IFR can change and can actually normalize, or if not normal, then above that threshold. And so I think that's a question that in some cases remains to be determined. It makes sense that visually we're not as good as we are by this quantifiable measurement. But on the other hand, I'm not sure people completely appreciate how dynamic that physiology really can be depending on the state of flow and the needs of the territory.
Online questions? No online questions. So.
Wonderful job.
Well, thank you all very much for your attention. I appreciate the opportunity to present.
Thank you.